Inga mana, inga reo, inga tā wira pumanawa, ro rakatira ma, tena koto, tena tato katoa. My name is Harleen Hain, and I have the great privilege of being the Vice Chancellor here at the University of Otago, and it is my great pleasure to welcome you to this inaugural Professorial lecture. As I look out tonight, I see the normal cast of characters. We've got staff and students from around the university, and we also have members of the general public who are always warmly welcomed to these inaugural Professorial lectures. We also have some special visitors here this evening. Our Chancellor, John Ward, is here, as is our former Vice Chancellor, Professor Sir David Skegg. But I'd also like to extend a very special welcome to three other guests that we have this evening. Tim's wife, Jo, and his two sons, Tom and Ben, who are also here this evening. So collectively, we are all here tonight to celebrate the appointment of Professor Tim Stokes to the Elaine Gerd Chair of General Practice in the Department of General Practice and Rural Health. Now, it turns out that teaching and research in the area of general practice and rural health is more important than ever in New Zealand, as we are trying to continue to stretch our healthcare budget by greater reliance on primary care. Although the World Bank estimates that only 14% of New Zealanders live in rural areas, the World Bank defines rural as a population below 30,000. So, although most folks in this country actually live in places with a population greater than 30,000, only the top 6 cities in New Zealand have a population greater than 100,000. So what this means for healthcare is that we need to rely more heavily on primary care, not only now, but in the future. So with that as a backdrop, we are incredibly fortunate to have someone with Professor Tim Stokes' skills and expertise as part of our Faculty of Medicine. Now, when we were considering Tim for this position, we sought feedback from internationally recognized experts in his area of work. And one of them told us, Tim is an exceptional doctor, researcher, manager, and colleague. If you were to appoint him, you would have a leader who will make a national and international impact on the field. I am sure that as you listen to him tonight, you will agree that Tim is already fulfilling that promise here at the University of Otago. So, Professor Stokes, although you took up your position in 2014, I would now like to officially welcome you to the University of Otago, and we are extremely pleased to have you here. I will now call on the Dean of the Dunedin School of Medicine, Professor Barry Taylor, who will tell us just a bit more about Tim's academic journey to Otago.
Thank you very much, Harleen. Harleen's beautifully summarized the context right at the moment. We are in a time of major change and changing systems, especially in primary care. So it's critical to base what happens in the southern region and indeed across the country on the best of what can be sort of pulled together from the international literature. So it's apposite to actually introduce Tim. He comes to us from the UK. And he did his undergraduate training in Oxford, and then followed on from that his medical training, a mixture of Oxford and then in his clinical years in Edinburgh. So Edinburgh being named very much the same name as Dunedin. Dunedin is, I think, the old name of Edinburgh. If you go to Edinburgh, you'll see it on the side of the road. So he's actually just come home, so to speak, to probably slightly better weather, I think, than Edinburgh, but many of the same traditions. During the course of doing his medical degree, he sort of interspersed it with doing an MA in history of medicine, focused on Victorian delivery of healthcare, which I think we'll hear a bit more about tonight. So that illustrates, I guess, some of the depth. Some of his postgraduate activity that we were particularly impressed with in appointing him was his involvement in NICE, which is the National Institute for Clinical Excellence, if I remember rightly, in the UK, which is probably the preeminent body, probably across the world, in terms of synthesizing evidence into practice, and especially in the UK. And certainly I always look up NICE guidelines when I'm looking about a clinical problem or trying to decide where the summary of current evidence sits. So NICE is one of the, I guess, and being a director of the medical side of that, based in, I think it was in Manchester, was one of the key attractions. Somebody who's actually used to synthesizing all the information into guidelines and actual practice. And that's really one of, I guess, our clear goals in appointing him. Since arrival, he's demonstrated active involvement in local processes in particular, and national. So he's already involved with Pharmac in terms of some funding decisions around various drugs. But more important to me, locally, he's been actively involved in the PHO and the DHB, has led a work stream around how we respond to acute care in the southern region, and is part of the ongoing discussion about how the model of care for primary care and how it should feed into a rebuilt Dunedin hospital. So there's a lot of things happening in this particular area at the moment, and it's really wonderful from my point of view to have somebody with Tim's caliber to actually support that whole process, which needs all our brains actively involved in. So he came with his wife and 2 children, all been introduced. Thank you very much for coming, and has settled into Dunedin, I believe, really well. He spent his first year and a half protected, I think, from head of department duties so as to establish his research activities, and now he's doing both research and active head of department duties, and I've been really impressed with working with him during that time. So it's really with great pleasure, perhaps slightly delayed, 2.5 years since he actually started, but still it's a wonderful occasion to celebrate actually becoming a professor and demonstrating really the journey that leads to that, and I'm looking forward to hearing the many bits that will have contributed to, in fact, his journey to the current state. I guess I'm even more interested about what will happen in the next 20 years as he delivers on the promise of what's led up to now. So now is a point in time. Thank you very much, Tim. Welcome, and we look forward to listening to you.
In October 2013, I made a decision, together with my wife Jo and my 2 boys, to embark on a rather big adventure, to make a career from the United Kingdom to New Zealand and the University of Otago, and to establish a new life for myself and my family. We arrived in the middle of the Dunedin winter in 2014.
Right, okay. It's working now. Fantastic. You haven't missed anything. 2.5 years on, happily established in St Clair, I can honestly say that we are all really pleased we took this huge step. I'm very grateful to the University Appointments Committee for considering that I had big enough feet to fill the vacant shoes of the Elaine Gurr Professor of General Practice here in the Dunedin School of Medicine. It's a real privilege to have the opportunity to shape the future of academic general practice in New Zealand. I'm also very grateful for the support and encouragement I've received from my colleagues in the Department of General Practice and Rural Health, within the Dunedin School of Medicine and Division of Health Sciences, and across the wider university. I would also like to specifically acknowledge the support of my peers on the university's excellent academic leadership programme. But above all, I need to thank my wife Jo and my 2 boys for having faith that a move to New Zealand would prove to be an enriching experience for all of us and allow us all to continue to grow as a family, not just for me to grow as an academic. Turning now to my inaugural professorial lecture, I have chosen the somewhat enigmatic title of The Road Less Travelled. I shall shortly expand on what this road is and what adventures I've had along the way, but first of all, I would like to reflect on a road more travelled, at least for medical practitioners, which is that of my choosing the medical discipline of general practice as a career. We GPs are the bedrock of medical practice in countries such as New Zealand and the UK. There are over 4,500 GPs in New Zealand, and we constitute 38% of the medical workforce. All of you in the audience will, I trust, have a GP, and many of you will have recently consulted one for advice. When I left medical school in 1989, I knew that I wanted to pursue general practice as a career. I saw it as offering an almost unique opportunity to combine diagnosing and managing a wide range of clinical conditions with the opportunity to be able to build up one-to-one relationships with patients over time. I've worked as a GP for over 25 years, and over that time have practiced in settings as varied as the Pennines of Yorkshire and Lancashire, the Fens of East Anglia, and last but not least, in inner city Leicester, in the East Midlands of England, serving a deprived and multi-ethnic population. I worked as a GP at the East Leicester Medical Practice for over 10 years, and would like to acknowledge the enormous social capital the partners and staff put into the practice so that it was a beacon of high-quality, accessible primary health care in a deprived area. Here, in the deep end of the inner city, we practice what has been termed poverty medicine. In a recent blog on his website, A Better NHS, the London GP, Jonathan Tomlinson, who practices in one of the most deprived districts of London, Hackney, talks about his struggles practicing this form of medicine. The things I struggled with most as a GP were my difficulties in trying to help people with chronic pain, anxiety and depression, loneliness, severe obesity, shame, self-loathing and self-harm. The consequences of deprivation and adverse childhood experiences. It wasn't that they weren't also suffering from heart and lung disease and the rest. They were, to a huge extent. It was just that managing these diseases wasn't half as challenging as the rest. And most of the time, it didn't seem to be the cause of my patients' greatest suffering. Poverty, of course, is not just an urban problem. I'd like to close my opening reflection on being a GP with a patient story. I was working as a long-term locum GP in the Fens of East Anglia in the mid-1990s. Visually, it was a bleak, flat expanse of land and water, partially redeemed by huge watercolour skies. The town I was working in had seen better days, the sort of place where no one left and no one came. Many of the population were or had been agricultural workers and lived in council housing, state housing to use the New Zealand term. In those days, I did total general practice, 9 surgery sessions a week, plus on-call overnight and a regular weekend on-call. I was working at 6 a.m. on Monday morning. I was tired. I'd been on duty since Saturday morning and had interrupted sleep both nights. The caller was the wife of a man in his early 70s. He had difficulty breathing, and from the history appeared to have chronic obstructive pulmonary disease, or COPD, a chronic lung disease. I decided to make a house call. The patient lived in a council house, sparsely furnished. I did the consultation in the sitting room, establishing that he did indeed have an infective exacerbation or flare-up of his COPD, a straightforward medical case. As I was listening to his chest, however, my gaze became fixed on the fireplace. It had a large built-in illuminated glass box on all 3 sides with something moving in it. I completed the consultation, agreeing a management plan and issuing a prescription. I then said to the patient, "I hope you don't mind my asking, but would you mind telling me what you have in the fireplace over there?" He smiled and said, "Doctor, that's Billy, the iguana." Me and the wife have loved Billy's company, but he's getting too big for the box, and we can't afford to keep him in there. You seem a nice, kind daughter. Would you like to look after Billy for us? I'm sure you can afford to give him a good home. Rather taken aback by this request to acquire a large green lizard, I was lost for words. I mumbled something like, "I'd think about it," and excused myself, suppressing a smile. As I was leaving, my pager went off, and it was time for another call. On reflecting on the case with the passage of time, It seems to me to have the bittersweet quality of the film Hunt for the Wilder People. Funny, yes, but also tinged with sadness. Managing the patient's COPD was straightforward, but finding a home for Billy most definitely was not. I often wonder what happened to Billy. Turning now to the focus of this lecture, which is my career as an academic GP. As academic GPs are, in contrast to both our hospital academic colleagues and our GP service colleagues, a rare species. It is indeed a road less travelled. In the UK, GP academics constitute less than 7% of clinical university academic staff and represent a tiny proportion of the total GP workforce. The same is true in New Zealand. Less than 0.5% of the GPs in practice in New Zealand are senior academic GPs, with there being approximately one senior academic GP per 300 service GPs. There are a number of reasons for our rarity, but I think a major one is a deep divide between a primary healthcare service delivered by independent practitioners working to a small business model and a fully publicly funded hospital service. This divide was created by the medical profession itself in the mid-20th century. It's now high time this divide is breached. You're also a relatively new academic discipline. I'm very proud to have my medical degree from the Dunedin of the North, Edinburgh. And one reason for this is that in 1948, Edinburgh established the first funded GP academic post in the world. A visionary professor of social medicine, Frank Crewe, recognised that the closure of the public dispensaries at the start of the NHS would mean medical students could no longer be taught in the community. Together with the GP, Dr. Richard Scott, he established what he termed a laboratory in the community to provide teaching to medical students and for long-term studies of illness within families. Scott became the first professor of general practice in the world in 1963. Some 20 years later, in 1983, Otago established the first New Zealand chair of general practice, courtesy of an endowment by Dr. Elaine Gurr. This entertaining cover from New Zealand Doctor, portraying the academic life as a roller coaster, features both the first Elaine Gurr professor, Emeritus Professor Campbell Murdoch, in the front row, with the second Elaine Gurr professor, Murray Tilliard, sitting on his own on the last seat at the back. There's actually therefore space for Murray because we've just appointed next to Murray, we've just appointed a new professor, Professor Sue Pullen, Professor of Primary Healthcare in Wellington. So there's space to join at the back. As you notice, I managed to get a second row seat, which I'm quite chuffed about, as only just arrived in New Zealand. In the 50-odd years since the Edinburgh Chair was established, general practice has established itself as a core academic discipline within medical academia. Academic GPs have made an important contribution in three main areas: teaching and learning, research, and service development, health policy, and clinical leadership. Special mention needs to be made of the American paediatrician and staunch advocate for primary health care, Dr. Barbara Starfield. Barbara was an early practitioner of healthcare delivery and organisation research and showed that health systems with strong primary care achieve better health outcomes for patients, lower costs, and greater equity in health. Her articulation of the four pillars of primary care practice has been hugely influential. These are first contact care, the need to be able to access and see a generalist practitioner before any referral to a specialist, continuity of care, the ability to see the same practitioner or team of practitioners over time who get to know you and your problems, comprehensive care to provide a wide range of clinical and preventive services, and coordination of care. Someone needs to hold a ring in terms of planning care and helping people navigate through the health system. Barbara's work was utilised in the recent model of a high-performing primary care system fit for the 21st century, developed by Bodenheimer and colleagues at the University of California, San Francisco. There are 10 building blocks on this slide. I'm not going to talk to them all, but the key message of this slide is that for high-quality primary health care, you do need to provide accessible health care. It needs to be delivered to a defined geographical population, and it needs to be comprehensive, coordinated, and delivered by a team, and that's both medics and non-medical people such as practice nurses, nurse practitioners. But above all, that team needs to value continuity of care. And this should be our vision for New Zealand primary care in the 21st century. Oops. So I have defined a road less travelled, that of academic general practice. But how did I come to be travelling along it? And what adventures have I had along the way? In a moment, I will tell you my story and highlight some of my family and mentors who have guided me. This is above all the story of agency, of an individual charting a path to his inaugural professorial lecture. But it's also a story of structure. The path I have trod was built by a particular set of economic and social conditions, and these have framed my sense of self, my consciousness. For I, like many I suspect in the audience above a certain age, am a child of the post-war welfare state. The ability to access and benefit from high-quality primary, secondary and tertiary education at little or no financial cost was instrumental in allowing me to study at 3 leading UK universities in the 1980s and to develop the ideas that form the basis for this lecture. My story begins at Victoria Hospital in Blackpool, Lancashire, in the northwest of England in 1963. It very nearly ended there, as I was one of 2 twin boys born prematurely and was not expected to survive. But survive I did, although the complications almost certainly left me with my hearing impairment. I might add that as a child, I found hearing aids highly stigmatising and refused to wear them. And so, given my desire to pass as normal, all my early career, right up to my last year at medical school in 1989, was spent as someone partially deaf in the land of the living. Oh, sorry, land of the hearing, I should say. Odd mixed metaphor there. I got by with augmenting what hearing I have with lip reading, and also by learning to read the room. And I trust you can understand why I never wanted to be a surgeon or an anaesthetist. I would now like to acknowledge the love and support of 2 family members who are not able to be here today, my mother, Gillian Smith, and my brother, Simon. My mum is very proud of her 2 twin sons. Never able to go to university herself or spread her wings, she has had compensation in seeing her sons achieve both of these things and seeing them live a life I am sure that she could have had too, had family circumstances been different. I'm also very proud of my mum. She has a quality that we parents all too rarely have, that of unconditional love for her sons. The move to New Zealand has come at a great personal cost, as I will see my mother perhaps every 2 years at most. But she has been a staunch supporter of the move, as she sees the benefits for her son, daughter-in-law, and 2 grandsons. This is my twin brother, Simon, who's on the right. Simon has been many things to me, not least a pair of ears, and we mingle with the same set of friends at school and at university. Ever competitive, at school I quickly learnt the way to come top was not to directly compete with my brother, as he always came top in the physical sciences and mathematics. Simon himself has travelled a road that began with studying metallurgy and materials science at Oxford, researching semiconductor industry policy at the Massachusetts Institute of Technology, and then forked into training as an intellectual property lawyer. He's London solicitor and authority on art and copyright law. Simon and I attended a direct grant, that's fully state-funded, grammar school some 7 miles inland from the Lancashire coast, Kirkham Grammar School. Kirkham Grammar School, or KG as it was known, offered an excellent all-round academic education, being particularly strong in science. I decided to embark on a career in medicine, and in 1982 went up to Lady Margaret Hall, Oxford, to read medicine. To arrive at Oxford in 1982 as a Northern Grammar School boy was the opening of a new world. On the one hand, Oxford, together with Cambridge, offered an unparalleled intellectual experience. On the other, that experience was tightly entwined with the English class system. For I had moved from an environment in which we had all taught pretty much the same and in which there was little social distance to one in which accent, school and who you knew did matter. I was now defined as coming from the north, pejoratively pigeonholed in those days as being, quote, a northern chemist, unquote. At Oxford, I became active in Labour Party politics, and in particular within the University Fabian Society, of which I was treasurer, the Fabians being the intellectual wing of the Labour Party. We invited a range of established and rising Labour stars to talk to the society, and I have fond memories of meeting one of New Zealand's brightest political exports, the MP for Dagenham, Brian Gould. If I had not studied medicine at university, I would have read history. Aware that Oxford had a welcome unit for the history of medicine, I wrote to director, Dr. Charles Webster, a letter saying that I was interested in the subject and would like to know what opportunities there were to pursue this. A letter quickly came back, inviting me to have afternoon tea at the unit on the Woodstock Road, and the rest, as they say, is history. Charles was in Oxford, but not of it. He trained as a science teacher in Sheffield and had taught chemistry at Sheffield City Grammar School before moving into academia at the University of Leeds. He was also a passionate believer in making his historical research accessible to a wider audience through his work with the Open University and the Workers' Educational Association. Through Charles's mentorship and support, I took a special option as part of my BA Physiological Sciences and then secured British Academy funding to intercalate an MPhil in the history of medicine at Peterhouse, Cambridge. It took me on an intellectual journey, which gave me a different way of looking at the production of medical knowledge and practice than that used by biomedicine, that of what sociologists have termed social constructionism. It also led to my first research paper, a piece of historical research. This paper explored the role of the pathologist, surgeon and public health officer, John Simon, in the parliamentary campaign to reform the medical profession in mid-Victorian England. I left Oxford in 1985 to do my clinical training in Edinburgh, another road less travelled, as almost all my compatriots had gone to Oxford, Cambridge or London to complete their studies. Edinburgh was socially a breath of fresh air, with a much more mixed intake of students, and I particularly enjoyed the teaching and the training I received in paediatrics, psychiatry and general practice. It was also at Edinburgh I experienced the hidden curriculum, the unintended curriculum that can have powerful effects on student attitudes. And it was in the old Royal Infirmary of Edinburgh that the force of this curriculum was most strongly felt. One story will suffice. I was on a Saturday morning post-hoc ward round as a fourth-year student. It was my turn to present the patient I had clerked, a man in his late 60s with COPD. I just finished my history of the presenting complaint when the consultant, the medical school professor, stopped me and said, "Stokes, where does the patient come from?" "Gorebridge," I replied. His reply was unexpected. He said, "They're all mad from there. Next patient, please." The answer, I think, is actually a simple one. Gorebridge is the next mining village in Midlothian with significant pockets of social deprivation. The patient was an ex-miner. He wasn't mad, he was poor. And the poor get a very raw deal from the health service. I graduated from Edinburgh in 1989, did my first house job in surgery in York, and met my wife Jo, then a student nurse, while I worked on the urology ward. I can assure you that's been the subject of a few jokes in its time. We decided to return back to the north of England, and I got a place on a general practice vocational training scheme in West Yorkshire at Airedale General Hospital. Airedale is 40 kilometres northwest of Leeds and serves a large geographical area with high urban deprivation to the south in the former mill town of Keighley and a more affluent rural population extending into the Yorkshire Dales National Park to the north. On paper, the Airedale scheme is unremarkable. There are dozens of similar schemes based in similar district general hospitals in the north of England alone. However, the course organisers certainly recruited people who thought outside the box. Of the 12 or so GPs who went to Airedale in the early 90s, 4 of us became academic GPs, 3 professors and 1 senior GP educator. David Pearson on the right, in fact, trained in me at Edinburgh. This is a quite amazing achievement, and to this day I'm not quite sure why that happened, but happen it did. It was in 1995 that I embarked on a career in general practice and laid the foundations for our major research theme, implementation research. Implementation research is a scientific study of methods to promote the systematic uptake of clinical research findings and other evidence-based practices into routine practice, and hence to improve the quality of healthcare. And over the last 20 years, I've conducted research across the implementation spectrum. For as this slide shows, such research spans all levels of the health system, from what happens in the individual consulting room between GP and patient, through to what happens in the GP practice, what happens at district health board level, and lastly, what happens at central government level. My GP research career did not, however, start in an academic department of general practice. It started as a registrar in public health medicine at the Leicester Health Authority in Leicester. I consider that the academic discipline of public health, through its membership examination and masters in public health, provided a good grounding in the study of the distribution and determinants of health related states in the population, what is called epidemiology, and in medical statistics. It would also give me a broad understanding of how a whole system operates and is connected, and last but not least, would furnish me with the skills needed to negotiate with, and earn the respect of, senior hospital clinicians and health service managers. I was given as my first task to be for working with local genitourinary medicines consultants to develop new ways of delivering sexual health services across primary and secondary care. I utilised this service brief to set up a programme of local implementation research in Leicestershire that addressed the interrelationship of genitourinary medicine clinics, family planning and general practice, and developed and implemented a methodology for the development of evidence-based clinical guidelines for a common sexually transmitted infection, genital chlamydial infection. Clinical guidelines in plain English are recommendations for health practitioners that advise on best practice in the diagnosis, investigation and treatment of common clinical conditions and illnesses. This local healthcare quality improvement work also led to the award of my first local research grant in collaboration with a new lecturer in health policy in the Department of Epidemiology and Public Health at the University of Leicester, who just finished a PhD, Dr. Mary Dixon-Woods. It was a qualitative study that explored women's accounts of choosing and using specialist services for sexual health. Qualitative research is now widely used in medical research and involves the collection, analysis, and interpretation of data that are not easily reduced to numbers. These data relate to the social world and the concepts and behaviours of people within it. I'll say more about Mary shortly. What was also interesting is that skills I developed then I'm still applying today in New Zealand. We are currently using similar methods in a Health Research Council-funded partnership grant with the Southern District Health Board to improve care for people with severe chronic obstructive pulmonary disease. This disease has now appeared 3 times in this talk, across the southern region. The decision to focus on developing clinical guideline methods in the mid-1990s, at a time when such methods were new and experimental, they had not yet been taken up by national government agencies, gave me a lucky break. In October 2001, having just finished a fixed-term clinical lectureship in general practice, in the throes of submitting my PhD, my funding had dried up, and I was working full-time as an in-city GP in Leicester. Any future path in academia looked uncertain. It was then that I was approached by my Leicester colleague, Professor Richard Baker, to apply for a National Institute for Clinical Excellence, or NICE as it is known, funded senior lectureship. The task was to set up and run a collaboration between the University of Leicester and Sheffield and the Royal College of General Practice. The collaboration was to develop clinical guidelines of high relevance to primary care for the NHS in England and Wales. Thus began a career that now spans research and national profile in healthcare quality improvement and part-time clinical practice. For this, I must thank Richard Baker, an academic GP with a passion for quality in healthcare, who supported me as I grew into this role. NICE was set up in 1999 as an independent organisation to reduce variation in the availability and quality of NHS treatments and care, and is now part of the furniture of the NHS, being seen as a leading international organisation in healthcare quality. I consider NICE's 3 achievements from an academic perspective are the normalisation of health economics, in particular cost-effectiveness analysis into decisions about new and existing technologies such as pharmaceuticals, the development of a strong patient and public involvement, and development of a transparent social value judgment framework. However, when NICE was set up in 1999, its future seemed far from certain. The average life for the government quango then was 18 months, and there was no shortage of vested interests who wanted to see NICE fail. When the then Labour Health Secretary, Frank Dobson, was asked, "Will it work?" Dobson replied, "Probably not, but we'll have a bloody good try at it." Thus, those who left secure NHS management or academic posts to join it in its early years were taking a considerable risk. One such person who left the chair at public health at St George's Medical School to become its clinical and public health director was Professor Littlejohn, Peter had in fact trained as a GP before going into public health. Peter was a great colleague and mentor during my time at NICE, and we both returned to academia at about the same time. And I'm very pleased to be able to collaborate with Peter on a Lotteries Health grant on assisting the firm's decision-making in the New Zealand health sector. The NICE work allowed me to apply my skills on the national stage, and the group I led produced a range of clinical guidelines on common mental conditions with high relevance for primary care. Examples include the first integrated public health and primary care guidance on obesity. I'm particularly proud of being able to use my soft influencing skills to get the Department of Health to commission NICE to develop a guideline on antibiotic prescribing for respiratory tract infections in primary care. Such conditions are the bread and butter of same-day appointments in primary care. Coughs, colds, earache and sore throats. The guideline was well received in the UK and has recently been launched in New Zealand. It's the first guideline to be contextualised for use in New Zealand under an arrangement between NICE and Dunedin's Best Practice Advisory Centre, led by my predecessor, Professor Mary Tilliard. If anyone thinks national clinical guidelines don't change clinical practice, look at this slide. The publication in March 2008 of a NICE guideline we developed restricting antibiotic use for the prophylaxis or prevention of a heart condition, infective endocarditis, was followed by a highly significant reduction of nearly 80% in antibiotic prescribing for prophylaxis in England. Over time, I also became more involved in the implementation of guideline recommendations. One major programme was the development of clinical performance measures or indicators for the National Performance Framework for UK General Practice, the Quality and Outcomes Framework, or QOF. There was an increasing concern in 2012 that one set of indicators which incentivised the routine use of questionnaires to assess the severity of a common mental illness, depression, were not working as intended. I proposed that my NICE team should design and conduct a systematic review of the evidence for a depression indicator set. The review demonstrated that the indicators most likely did not improve care and had adversely affected the process by which GPs diagnose and manage depression. The review had a major health policy impact. It led to the removal of the indicator set from a national performance framework. I think I have said enough about implementation research and NICE. I'd now like to take you towards the end of my journey and tell you about my other research theme, that of health practitioner-patient relations in primary care. As I mentioned earlier, one of the key defining features of primary care is providing personal care to the same individuals over time, what is called relational continuity of care. I cannot a range of research studies in this field covering continuity of care, the nature of personal care, and difficult doctor-patient relationships. And I want to tell you about one particular piece of health practitioner-patient relations research I conducted. It's my University of Leicester PhD thesis, and I'm proudly wearing my Leicester academic regalia as I lecture. And there's really three reasons for talking about my PhD. The first is that I owe it to my wife, Jo, to do so. As she still has memories of the 4 years she spent as a PhD widow, and I'd specifically like to thank her for the patience and many cups of tea made during the write-up phase when I would home myself in my study most weekends. The arrival of my PhD was also not long followed by the arrival of my firstborn, Tom. Second, this is another road less travelled. In 1997, a 4-year clinical lecturer post in the Department of General Practice and Primary Care at the University of Leicester became vacant. I decided that now was the time to step out of public health, take up my first academic position, and follow my MPH with a PhD. In choosing my PhD topic and approach, I felt I had a unique opportunity to address some unfinished intellectual business. I got interested in medical sociology while doing my Cambridge master's thesis 10 years previously and was keen to do a PhD using quantitative methods that would allow me to learn, apply and develop relevant sociological theory to my general practice topic of study. I was very fortunate in having two supervisors who together were able to make this journey, a rare one for medical practitioners, a success. My GP supervisor was Dr. Bob McKinley, a senior lecturer in the department now at the Keele University School of Medicine. A number of you will remember that I had Bob out here at the University of Otago last year as a William Evans Fellow. Bob is an excellent clinician, medical educator, researcher and colleague, and is possessed of a keen intellect. He's also been the best mentor that I've ever had. My sociology supervisor, Dr. Mary Dixon Woods, with whom I had collaborated earlier on the sexual health study. Mary has a towering intellect, can marshal sociological theory in a highly accessible manner, and writes better than anyone else I know. I was Mary's first PhD student. Mary has since had a distinguished career in health quality and safety research, which led to her appointment to the RAM Professorship of Health Services Research at the University of Cambridge last year. As supervisors, Mary and Bob were like chalk and cheese. My PhD was entitled Ending the Doctor-Patient Relationship, an investigation into the removal of patients from GPs' lists. Its aim was to obtain a detailed description of the process of removal as perceived by both practitioner and patient, and to place removal in a wider framework of theory in relation to the difficult doctor-patient relationship. In the series of 4 papers I published from this work, I was able to offer a rich description of removal from the perspectives of both GPs and patients. And I'm particularly pleased to have been able to use the sociologist Irving Goffman's classic work on stigma to help make sense of the patient's accounts in the research paper we published in the British Medical Journal. I was also able to make a more general model of why doctors end relationships with patients and make practical recommendations as to how GP practices can better manage such situations. Last, I was able to publish a sociology paper in which we applied the French sociologist Pierre Bourdieu's theory of practice to my PhD findings. My appetite for sociology was now about well and truly sated. The final reason I'm talking about my PhD thesis today is that it set the road in the direction of Otago. My PhD work led me to a paper which Dr. Chris Jay had co-authored in 2002 on why patients change doctors at the university, at the Dunedin School of Medicine. Chris and I started corresponding, and I ran a research seminar at the department on our first family visit to New Zealand in 2005. Tom at the time was 2.5. Ben wasn't here. I was struck at the time by what a wonderful university Dunedin was. The memory dimmed with the passage of time, to be relit when an email about a vacant position at Otago unexpectedly arrived in my University of Birmingham inbox in May 2013. It's now time to draw this lecture to a close. I consider, in telling my story, I have taken a series of choices I have made in my career, choices that at the time I may only have dimly seen, and weave them into a narrative with the benefit of hindsight. Such is one interpretation of the poem which provides the title for this lecture, The Road Not Taken, by the American poet Robert Frost. I'll leave you with its last stanza. I shall be telling this with a sigh somewhere, ages and ages hence. 2 roads diverged in a wood, and I took the one less travelled by, and that has made all the difference. Thank you.
Is that on? Nā koutou katoa. That is on now. Good, thank you. My name is Peter Crampton. I'm the Pro-Vice Chancellor of Health Sciences and also the Dean of the Otago Medical School. Greetings, everyone. It is my pleasure to thank Tim for his exceptional inaugural professorial lecture, and also to highlight a few of the key points and maybe draw some insights from his lecture. First of all, thank you, Tim. That was really, really enjoyable. IPLs give us the opportunity to hear a narrative from the voice of a professor as they help us to understand the pathway that they have travelled
or a pathway less travelled in Tim's case, through their career and to weave a story for us, and that he's done very well. Geographically, of course, he's told us a story which spans his beginnings, his growing up, the Fens, Blackpool, Lady Margaret Hall, the University of Edinburgh, and many other places, including Airedale, and of course all the way to Dunedin. But he's also given us insights into his academic journey, particularly focusing on implementation research and healthcare delivery research, spanning qualitative and quantitative methodologies, which is a significant component of his approach to his academic work. And he's touched on numerous and diverse topics, including antibiotic prescribing, depression, and so on. And also he's informed us of his interest in and love of sociological approaches and how he has applied these to topics such as aspects of the patient-doctor relationship. Thank you, Tim, also for sharing some of your family stories with us so we can understand where you come from as a person. We've learned something about your personal journey and also the key inspirational figures in your academic journey. I was delighted to hear the reference to Barbara Starfield. I don't know if you know this, Tim, but I had the privilege and the pleasure of working with Barbara for a year back in the early 2000s. Sadly, she's passed away now. But some of your points were so well illustrated when I was working with her. She is an intellectual pioneer, particularly in the context of the United States primary healthcare system, which is generally weak, with some highlights of strength. And one of the pillars that Tim referred to was comprehensive care. And while I was working with her, Barbara's very elderly mother was admitted to a hospital with a fractured neck of femur, a fractured thigh, which is a common injury in elderly people. And that was duly operated on and fixed. And while she was in hospital, she had a number of specialists looking after her in a very fragmented way. And one of those specialists noted that she had a drop in her blood glucose level one day. What she needed was a barley sugar at that point, or a sweet cup of tea. Instead, this specialist, working in isolation from all the others, stuck a needle into her pancreas to check out the very unlikely possibility in this 92-year-old woman of an insulinoma, a rare tumor. And that intervention, that investigation, killed her. She died as a result. And this was a poignant and tragic reminder and illustration of Barbara's passion for comprehensive care and strong primary health care. So, Tim, you are making a tremendous contribution to academic general practice and to health systems development in New Zealand, and we hope you are with us for a very long time for that contribution to mature and develop as New Zealand's health system develops along its own particular pathway. The experience and background that you bring to us is tremendously relevant and valuable to us as we struggle with many of the issues that you've described from a UK perspective. So once again, congratulations and thank you so much for treating us to such a great IPL. I would like to make a very small presentation now, if I could, of our appreciation. This is a traditional presentation that we make at the time of an IPL. Thank you.
Thank you very much.